Enteroscopy is an invasive procedure, a costly procedure, so we need to use it when we really in need of it. What we know is that the inflammatory bowel disease, Crohn's disease, affects every part of the bowel, including the small bowel. We know that the small bowel is very difficult to examine, but we have several methods to examine: intestinal ultrasonography, CT, MRI, capsule, and lastly, enteroscopy. However, enteroscopy is a good way because it gives something in excess. It gives you tissue biopsy, better image quality, and it's diagnostic and sometimes therapeutic procedure. However, it is invasive procedure, costly procedure, taking time and effort. So many questions here. The first question is that how frequent is Crohn's disease of the small bowel? The clinical studies have shown that 30 to 70% of patients have a small bowel involvement in addition to the colon. However, up to 30% of patients can have only small bowel involvement. The questions here are, when do we have to ask for enteroscopy? Is it the first, second, or third study you should ask for? And what to do and what you expect enteroscopy to tell you? And when not to ask for enteroscopy for these patients. To start with, do I need enteroscopy or not? Let us give some examples. A 25-year-old young woman presented to you with abdominal pain and diarrhea of 6-month duration. Her C-reactive protein is high, fecal calprotectin is elevated, the rest is normal. You did upper and lower endoscopy and the terminal ileum is normal. However, you did a CT enterography and you find something in the small bowel. So what's your choice here? Capsule, MRI, ultrasonography, enteroscopy, or start treatment at once? I think all of you will choose enteroscopy to have a tissue biopsy. You suspect Crohn's away from the reach of EGD colonoscopy and you want to confirm. This is the first message. The second case is a 34-year-old man, a known case with Crohn's disease, well controlled on video, presented with postprandial colicky, abdominal pain, distension, and constipation. His lab is okay. You had an MRI which showed a 2 centimeter proximal jejunal stricture. The rest of the study is okay. Which examination you would like to do? Yes, because you are going to do intervention and to see what's the stricture. So if you have symptomatic stricture and you want to dilate, this is enteroscopy. A 25-year-old young woman presented to you with abdominal pain and diarrhea of 6-month duration. C-reactive protein is elevated, fecal calprotectin elevated, the rest is okay. Upper and lower endoscopy are okay. You decided to do capsule endoscopy, but the capsule got impacted. What to do? Again, enteroscopy to take it out. So you need to remove an impacted foreign body proximal to a Crohn's stricture. This is the third indication. A 25-year-old man, known case of Crohn's disease, presented to you with recurrent melena. Upper and lower endoscopy did not show the cause of bleeding. You know he is having Crohn's disease. Which one to choose? Capsule endoscopy, CT angiography, ultrasonography, enteroscopy, something else. You have many options, but one of these options is capsule endoscopy to see the source of bleeding, CT angiography to see the source of the bleeding, and enteroscopy. Any one of these you can use. Use the one you have in your facility. You need to diagnose or control small bowel bleeding, so enteroscopy can help in this. A 25-year-old young woman presented to you with abdominal pain and diarrhea of 6-month duration. C-reactive protein is high, fecal calprotectin high, the rest is okay. Upper and lower endoscopy to the terminal ileum is normal. CT enterography is unremarkable, no strictures. So again, this patient, the CT enterography is normal and no strictures, and you have something fishy, and your upper and lower endoscopy are normal. You are still suspecting Crohn's disease. Which one to choose? Yes, capsule endoscopy, non-invasive. You don't have possibility of impaction. Enteroscopy and GIT societies. The societies in the American College of Gastroenterology are saying that deep endoscopy is not a part of the routine diagnostic testing with suspected patients with Crohn's disease, but may provide additional information in patients who require biopsy, sampling, tissues for diagnosis. The European are more elaborative in this. They are saying that device-assisted enteroscopy with a small bowel biopsy in patients with non-contributory ileocolonoscopy and with a suspicion of Crohn's disease on a small bowel cross-sectional imaging. And again, device-assisted enteroscopy is more likely to provide definitive diagnosis than cross-sectional imaging. Also, the latter offers a useful, less invasive testing. Again, is indicated in other situations like dilation of Crohn's stricture and retrieval of foreign body, as I have shown you before, or small bowel bleeding. So the key message is that enteroscopy is useful in suspected small bowel disease away from the reach of upper and lower endoscopy. Enteroscopy is useful in dilation of short strictures of Crohn's disease away from the reach of upper and lower endoscopy. And we have new changes. What are the new changes? The marked removal of power spiral of Olympus because of safety issues is not available anymore now. New techniques in the stricture dilation, including incision of the stricture followed by the dilation. This is making dilation more effective and less frequent. One of the non-indications of enteroscopy, patients presenting with abdominal pain and you are suspecting Crohn's disease and everything is normal. The imaging is normal, the lab is normal, and you don't have anything in the examination or in the inflammatory markers. This is not an indication of enteroscopy. Pain alone without inflammatory markers is not an indication for enteroscopy. The outcome is very low. Thank you.